here's my kind of typical spiel, if you
Yeah.
will, for
Yeah.
a newly diagnosed testicular cancer patient. First things first, you're going to be okay. There's no stage 4 testicular cancer. We're curable across disease states. Um, with that in mind, it's absolutely critical that we do everything perfectly to make sure that we cure you, and also to make sure we don't do anything to hurt you for the next 50, 60, 70 years of your life. Listen, you're a young man. For a few more years, I'll still be a young man-ish. And I think for young, healthy men that are kind of cruising through new cancer diagnosis, that can obviously rock your worldview. And I'll tell them explicitly that we do see anxiety, depression associated with these cancer diagnoses, and offer them a consultation to our cancer center support services or psychology or psychiatry, just to let them know that that's normal to be, worried about the whole affair.
Absolutely.
Then it starts with staging, and it's kind of easy to explain. The bulk of these patients coming in, seminomas or non-seminomas, are stage 1, so that's going to be cancer confined to the testicle, and assuming their CT scans top to bottom are negative and their markers have normalized, they're stage 1. Particularly for for all these patients, and it might be somewhat useful to talk a little bit about non-seminomas versus seminomas. So for the seminoma stage 1, really barring anything extremely outstanding, I'm recommending surveillance. If they have extreme anxiety or contraindications to any of the available options that could exist, I'm going to recommend surveillance. Now, there are some prognostic factors which aren't as strong as they are in the non-seminoma world. Size of the tumor, ready testes invasion, some newer data on lymphovascular invasion that can predict the likelihood of metastases. But the overtreatment rates are high if we do any type of adjuvant therapy, and those would be carboplatin or radiation. So, and they're not free rides, they're not risk-free.
Right.
So basically, there's infrequently nevers in any medical field, but I almost never recommend any type of adjuvant therapy for stage 1. And I'll tell them their risk of a relapse, all comers, is about 15 to 20%. If they've got all the risk factors, it's kind of closer to 40%. If they have none, it's more in the 5 to 6% range, just so they know. And I'll, of course, tell them that if your cancer recurs, we have highly effective ways of curing you.
Right.
Stage 1 non-seminomas, really outside of the clinical entity of teratoma with some somatic malignancy elements in the primary, again, really kind of pushing for surveillance for the stage 1 non-seminomas. Risk factors, lymphovascular invasion, carcinoma predominance, those are going to be elements where they're going to be at a bit of a higher risk. We do have all these patients visit us in the context of a multidisciplinary germ cell tumor-directed tumor board. They meet with medical oncologists, myself. They hear about all their options, but we generally would advise for surveillance almost across the board.
And then how often do you follow these patients, and what does your surveillance look like?
Yeah, sure. So, it's pretty much guideline directed. There's the NCCN, there's the AUA, which I think have very reasonable guidelines, and it's some combination of a slightly more intensive surveillance during the first year, typically an H&P with tumor markers every 2 months, chest x-ray, and abdominal imaging every 4 to 6 months. So the higher risk patients, I'm going to be on the 4-month end of the spectrum. The lower risk patients more on the 6-month end of the spectrum. And for the seminomas, I do get MRIs based on a nice randomized trial that was conducted out of the UK.
Absolutely. And what did that trial what does that trial indicate?
Yeah, so that trial is called the TRIST study, and they basically compare CT scans versus MRIs, and they compared the frequency of imaging of either 1, 3, 7 scans versus 1 versus 3 versus 7 scans over their study period. And suffice it to say that MRI versus CT had no difference in recurrence detection rates and stage detection, and the slightly increased interval between scans, you see a non-significant minor increase in the rate of minimally advanced disease. So I think the idea of kind of decreasing anxiety, decreasing cost, decreasing ionizing radiation with somewhat less frequent scanning is going to rapidly become a standard.
Absolutely. That's great. And what about for some later stages?
Yeah, so maybe we'll start out with the easy ones, chip shots.
Yep.
Stage 3, that's you should be appropriately staged with the critical elements of the ICG International Germ Cell Cancer Collaborative Group risk stratification, where we're taking in post-orchiectomy tumor markers, we're taking at sites of metastases, and a patient's going to be assigned a good, intermediate, or poor risk, and that's going to dictate their systemic therapy. And that absolutely should be done unequivocally. And then to oversimplify, so we do see these patients on the front end, specifically for the non-seminomas, just so they've kind of heard the possibility of a post-chemo RPLND. And so after they complete their chemotherapy, they get restaged. And to oversimplify, men with persistent residual masses greater than a centimeter are typically counseled towards RPLND. For non-seminomas, if it's less than a centimeter, generally we will observe them. It's nuanced and there's shared decision making, but that's kind of a broad strokes. For the seminomas, there's no poor risk. They get their appropriate risk-directed chemotherapy, then they get restaged. And suffice it to say that we're fairly careful in who we would advise subsequent treatment in the post-chemo setting for seminomas, looking at their size of their mass, continued involution, growth. Growth is going to be kind of the most unequivocal sign that they may need salvage chemotherapy or possibly an RPLND. But really, it's going to be a deliberate process of monitoring in the post-chemo seminoma setting. Stage 2 is kind of exciting, despite the fact that it's a relatively slim proportion of the patients that come in.
Yeah.
There's really quite a bit of energy devoted to it, and I think it's great. I think it's really nice that the germ cell tumor community continues to try to evolve and find better options. So maybe we'll start out with stage 2 non-seminomas. I think practically you could say the first major fork in the road is the volume of stage 2 disease. It's kind of broad, nodal disease only outside of significantly elevated tumor markers is going to be all stage 2 disease. It could be a large 10-centimeter mass. This could be, a small little lymph node that's a centimeter. So maybe to oversimplify, if your markers are elevated stage 2, that's chemo. That's pretty straightforward. Stick with non-seminomas. If your markers are not elevated and there's nothing kind of really compelling that the retroperitoneal disease is going to be teratoma, so lots of teratoma in the primary, cystic masses, marker negative. Suffice it to say that 3 centimeters is a kind of reasonable, I think, clinical cutoff. Anything bigger than 3 centimeters, broad strokes, you're more likely to get chemotherapy. Smaller than 3 centimeters, now we're digging in a little bit deeper. Size of the nodes we've talked about, number of nodes. My kind of rule of thumb is nothing more than 3 nodes. Are they in the primary landing zone? Any type of abnormal pattern of metastases, any suspicious metastases. So for those small volume, limited retroperitoneal disease, and also take into account whether they were stage 2 at presentation or stage 1 and recurred with retroperitoneal disease, you can have a conversation about either starting out with chemotherapy or starting out with surgery. There's rationale for both. So with surgery, we know about 20-30% of these nodes are going to be pathological and zero inflammatory. We don't want to give chemotherapy with all the long-term potential side effects, including secondary cancers and heart disease, to men who don't have cancer. That's not good. Ideally, you don't want to operate on them either, but you don't have perfect tools. And we may touch a bit on microRNAs, which are next generation tumor markers that are really, I think, poised to change the way people are treated. So in those stage 2 patients, surgery, you get pathological confirmation what you need. Generally, if they've got cancer, newer data suggests that with a well-done RPLND, they should have about an 80-85% cure rate, i.e. avoidance of chemotherapy. If there's any teratoma, you handle it there. And then generally, chemotherapy naive surgery is easier than post-chemo surgery. So those are the kind of rationales for starting out with surgery. Chemotherapy, you many times have a cure rate that approaches more, with one therapy in the higher 90s range. Some proportion of those patients are going to require a post-chemo RPLND for residual masses, but a lot of them have a complete radiographic response and they may not need anything further. There are some exposure to the side effects that I kind of mentioned with chemotherapy. But by all means, it's still a guideline directed option. I think the field is generally trying to shift away from chemotherapy in appropriately selected patients, just because we know that, now that these patients are living 50, 70 years, that they contend with some of these side effects. So small volume, limited RP disease, I think surgery makes a lot of sense. If it's more bulky, marker positive, patient preference, then, chemotherapy is absolutely a guideline directed option. Stage 2 seminoma, historically it was kind of chemo or radiation. Maybe radiation is falling a bit out of favor, because if you do recur, which occurs 10, 12% of the time, and you see chemo, now the likelihood of bad stuff, secondary cancers, is really becoming exponential. But if it's limited disease, we kind of started thinking that maybe we can do surgery on these patients and save them from chemotherapy. And really, over the last 18 months, there's been a lot of exciting data. The SEMS trial, Sia Danishmand was the PI for that. The PRIME test study, the COTRIM study, large series from Indiana, Memorial Sloan Kettering, Swinoteca, which say, to very broadly summarize, that surgery is safe, it's curative, and about 80 to 85% of patients, kind of what we expect with radiation, and many patients can avoid chemotherapy. So that's kind of slowly trickling itself. The AUA guidelines just endorsed it as a guideline directed option for patients with stage 2 disease. I think that's exciting. And otherwise, I do still think that shared decision making is critical for these patients.
Excellent. Yeah, and definitely in the last year alone, there's been a lot of data that supports surgery for these patients.
Yeah, so it's getting a little bit more nuanced, which I think is overall a good thing. Is there a best option? Probably not. I think we're taking in, patient-specific considerations to really tailor things.